بسم الله الرحمن الرحيم. مدرس مساعد اياد محمود عبداللطيف، تدريسي في كلية طب الاسنان جامعة الانبار. درس المرحلة الرابعة، هذه احدى محاضرات المرحلة الرابعة. بسم الله الرحمن الرحيم. نبتدئ. Treatment of deep-seated caries and pulp exposure. Deep-seated caries when the dentist is faced with deep carious lesion and the tooth has normal pulp. All the caries is removed and protect base such as calcium hydroxide or glass ionomer cement is placed between the permanent restoration and the dentine to minimize post-operative sensitivity and promote pulp tissue healing. Pulp exposure may occur accidentally during cavity preparation, mechanical or traumatic exposure. As a consequence of deep caries dentine, pathological exposure. Pulp capping. Pulp capping indication. The indication of pulp capping, a small mechanical pulp exposure, and surrounding dentine is clean and no history of spontaneous pain or inflammation. Pulp capping agent, calcium hydroxide, dical. It is an acceptable medicament in dentistry used for pulp protection. It has antibacterial action because of its high pH, 9.2. So, its alkaline can kill microorganisms in the area and prevent its effect, which causes sterilization of carious dentine. Also, it stimulates the formation of reparative dentine and pulp coverage. In this picture, we can see the direct pulp capping on the exposure site, and there is pulp reaction form of secondary dentine underneath the direct capping, and there is the filling for the other space of the defect, and there is dentine and pulp other tissue in this picture. The use of any calcium hydroxide should be kept to minimum because it's dissolved over time, resulting in unsupported restoration. This is one of shortcomings of uses calcium hydroxide. It's dissolved over time. So, what we can do? After any pulp exposure, the preparation should be disinfected with the Concepts chlorhexidine material for one company known as Ultradent. And when then derived, alternatively, we can use alternative to Concepts 2.6% sodium hypochlorite can be applied and then rinse off with water. Sodium hypochlorite also helps create hemostasis. An adequate amount of calcium hydroxide to cover the exposure should be applied, and then small amount of light polymerization resin modified glass ionomer should be used to cover the calcium hydroxide, creating bacterial barrier. The glass ionomer is sealing area, so prevent the dissolution of the calcium hydroxide and may be protected from dissolution by the saliva or other washing material. Mineral trioxide aggregation, MTA, a recent material which is used for many applications like treatment of root perforation, epixification, pulp capping, and root end filling. It has the following properties. So this material can use for direct pulp capping in this lecture, but also can for other procedure. It has the following properties: biocompatibility and no mutagenic potential. So it's biocompatible, not irritant to the pulp, promote healing. Great sealing ability. This is a feature that not found on the calcium hydroxide. So it's better than the calcium hydroxide. There is problem, and we resolve this problem by this material. This problem present in calcium hydroxide. calcium hydroxide sealing ability less than MTA, so the MTA preferred than calcium hydroxide. Other properties, 3, antibacterial activity. Antibacterial activity, the same activity present in calcium hydroxide. It's alkaline, with pH alkaline, that promote the killing of the microorganism. Low cytotoxicity, stimulation of mineralization tissue formation. This stimulation may help in formation of the dentinal bridge. However, MTA expensive. This is for the first time introduced. The mineral triclosan is very expensive. Now there is other company other than supply, so it's less expensive the material than before. Can see clinical application of MTA, mineral triclosan aggregation. Pulp capping, furcar repair, root resorption, perforation repair, epixification, root end filling. So it's wide spectrum of uses of this material. This material of dental supply in origin, it's expensive, then introduced by other company, lower level of company, so it's less expensive now. This is applicator in the left side. This applicator can use to condense this material if we use it inside the canal, ferical. Other newer material, ferical LC or Liticure, pulp capping material and liner. Ferical LC is dentistry's first Liticure flowable resin containing appetite stimulating calcium silicate. So the material contains calcium silicate, stimulates appetite, stimulates formation of secondary dentine, can use for pulp capping. It is the first of a new protective class of internal flowable. So it's flowable also. Flowable, it's easy to do, adaptable to the floor of the cavity to serve, protect and revitalization of pulp tissue, and will be described by the professional as RMCS, resin modified calcium silicate. So it's contain resin that set by Liticure, modified with the calcium silicate. The significant calcium release provide reparative ions. So this supply reparative ion that stimulate formation of mineral and create dentinal bridge in the exposure site. Create sustained alkaline environment required to promote wound healing. So also it's alkaline pH can promote wound healing and killing microorganisms. Provide immediate bond and sealing properties. This immediate bond promote the sealing and not need to the glass ionomer for sealing like calcium hydroxide. Stimulate hydroxyl appetite and secondary dentine formation with the affecting tissue. So can promote healing. Procedure of direct pulp capping. It is one appointment procedure which includes the following step. It's one appointment, one approach for exposure site. No open the exposure site again. So what that mean? That mean we can protect the area and not open the area again, and exposure to the other microorganism may lead to fail in the procedure. The fail must be isolated with the rubber dam to minimize bacterial contamination of the treatment site. This is mandatory, or at least preferred. Good isolation to successful of procedure. Soft carious dentine is excavated by sharp explorer. We must use sharp explorer. This explorer can remove the carious dentine without pushing of the carious dentine inside the pulp. Might compromise the healing of the pulp. We should be careful not to force carious dentine into the pulp chamber also. A cleaning agent is used like sterile water or saline solution, and no air should be used. Don't interrupt the air bubble inside the dentine near the pulp, or pushing the air inside the pulp chamber and increase sensitivity or degeneration of the pulp. After cleansing the area, the cavity is derived by cotton pellet and calcium hydroxide is placed. This is for direct pulp capping. If bleeding at exposure site is arrested and area is clean, calcium hydroxide is used. But if bleeding continuous, we can use calcium hydroxide powder. Is used to instead, and sharp excavator is used to remove the excessive material from the periphery. So, to avoid the exposure, we cover, or to avoid increase the exposure site, we cover the exposure site and remove the caries from the periphery. Glass ionomer cement is placed over the calcium hydroxide to protect the base and to enhance seal, and then zinc oxide cement is placed. Because the shortcoming of the calcium hydroxide is no sealing, we need to use glass ionomer cement to cover, to enhance sealing and protect calcium hydroxide from dissolution or resorption by any fluid, saliva or washing or other material. Pulp capping. For direct pulp capping to be successful, a number of factors have to be met, and these are: in field of history, no recurrent or spontaneous pain, because the recurrent or spontaneous pain refer to inflammation of the pulp, and this is effect on prognosis of this treatment. No swelling. Sure, swelling is indication of inflammation and extending of inflammation to periapical area. Preoperative assessment. Normal vitality tests. Any test used for vitality. Thermal, electrical, or other test present the tooth must be vital. No tender to percussion. Tenderness to percussion indicate of apical periodontitis inflammation and extension of the inflammation from the pulp to the periapical area. No radiographic evidence of periodicular pathology. In X-ray, we must not show thickening of periodontal or other lesion that we can see it indicated of an extent of inflammation to periapical area. Young patient. Why young patient? Young patient more vascular, more liable to healing, more liable to formation of dentinal bridge to close the exposure sites. As we know, in old patient, decrease in blood vessels inside the pulp and increase in fibrous and decrease in liability for build up of dentine to close the exposure site. Radiographically obvious pulp chamber and root canal. One type of the inflammation may causes of calcified the pulp chamber and root canal. Clinical finding: pink color, pink pulp, Pink, not red. Pink indicated of the pulp is normal, while red pulp indicated of inflammation. Bleeding, if touched but not excessively, because excessive bleeding indicated of inflammation. This sign may be benefit in treatment of vital bulb during the procedure. Indirect bulb cupping. It is 2 appointment procedure, not single appointment like direct. So 2 approach for the area of the carious dentine or deep carious dentine, which is preferred by many clinicians because the prognosis of this procedure is highly more than the direct pulp cupping, and it is more conservative and more likely to yield favorable result than direct pulp cupping. So we must remove all the caries except the deep caries that we suspect there is exposure when removed. This will enhance or increase the prognosis of our treatment. Procedure of indirect pulp cupping. The following procedures are applied. The field must be isolated like other procedure with rubber dam to minimize bacterial contamination of the treatment site. All peripheral carious dentine is removed with large round burr or spoon excavator. A large round burr or excavator, we can more control our procedure and less cutting or entrance to the deep area. The deep soft carious dentine adjacent to the pulp is left without removal. So deep, this one, soft, even soft, not hard carious dentine adjacent to the pulp is left without removal. Even the soft carious, when we suspect there is exposure, if we remove it, we leave it. This is protective area, not sealing area. The wall, we must clean all of it, but the deep area adjacent to the pulp must leave it, not remove, to protect the pulp. Calcium hydroxide is placed over the area, and glass ionomer cement is placed over calcium hydroxide to protect base and enhance sealing, and zinc oxide cement placed or direct restoration. Glass ionomer protect the calcium hydroxide from the solution and seal the area from the water or any humidity. Indirect pulp cupping, sign of clinical success of direct or indirect pulp cupping. After 4 to 6 weeks or more, the cement is removed and the internal surface of the cavity inspected for remineralization and hard dentine formation. We need at least 4 to 6 weeks to formation of dentinal bridge. So, if the procedure successful, after 4 to 6 weeks, we remove the cement and show the area if there is bridge removal. I prefer we take X-ray before we remove it. Dentine at suspected site should be hard, no bleeding, no sign of exposure. Also, the tooth should be asymptomatic and no history of spontaneous pain. If this factor or signs present, the procedure indicated is successful and can remove the caries. This is indirect pulp cupping. Although extensive irritation dentine has formed under carious dentine, it does not protect the pulp from effect of irritants, as shown by microabscess. This is, not the barrier that formed always indicated the successful procedure. Sometimes, although there is dentinal bridge and barrier form between the cavity and pulp, the pulp reaction tend to be inflamed. Why inflamed? Because some of microorganisms can penetrate from within the dentinal bridge, as we shown in figure on the right side, and reach the pulp and causes inflammation. Actually, the calcium hydroxide have many problems. One of the problems that is absorbable. Second, there is tunnel cavitation within the dentinal bridge, maybe sometimes large tunnel that microorganism can pass it to the pulp. Sometimes even it's successful firstly, but then it's failed. Other material may be better, like MTA and spherical light cure, as we mentioned before. This is photomicrograph for 4-layer of healing under indirect pulp cupping of permanent molar of 14.5 years old child. Zinc oxide eugenol cement cupping after excavation of the necrotic dentine layer only. No pain after 480 days later when extract. We can see the normal pulp with the slight increase in fibrous element reproduced with the permission from pulpotomy. Other procedure we dealing with the exposure is pulpotomy. It's conservative therapy performed to remove inflamed coronal portion of the pulp and preserve the vitality of remaining radicular pulp. So it's conservative therapy. That means we not remove all the pulp. We remove just the inflamed portion of the pulp and preserve vitality. Other side or other part of radicular pulp. Why we do it? Indication permanent tooth with incomplete root formation. So this procedure permits to complete the root formation and close the apex and can do endodontic treatment. And no history of pain and clinical no abscess. This is from indication. Extreme mobility, large carious lesion or mechanical traumatic exposure. Radiographically normal bone structure with no internal or external root resorption. So by X-ray we can check this sign. There's normal in bone, no resorption in root, and it's short-term preservative for permanent teeth until complete root formation and the tooth is ready for complete endodontic restoration. Many agents used in pulpotomy. Calcium hydroxide is most widely used, but also can use other alternative material, as we know, MTA, mineral trioxide aggregation, and spherical light cure. Other material may be used, especially in pedodontic, formacrysol glutaraldehyde. The following procedures are applied. The field must be isolated with rubber dam to minimize bacterial contamination of the treatment site. Amputation of the pulp and surrounding dentine at the depth of 2 mm beyond the exposure. So cutting the pulp 2 mm, partial pulpotomy, or remove all the pulp chamber to the orifice of the canal, and the cutting intermittent with the light pressure. So we can cut it by light pressure, maybe cut it by turbine. Establish hemostasis and cover the pulp with the calcium hydroxide and restore the tooth. Stop bleeding and put the calcium hydroxide, then we can restore the tooth. Sign of clinical success of pulpotomy. No clinical sign and symptom. So the tooth, if we want to know it's successful, this procedure, must no clinical sign and symptom, no pain, no swelling, no tenderness, no radiographic pathology. If we take X-ray, there is no pathology in the periapical area or root resorption. Continuous development of immature roots. After sequence of X-ray, we can check there is continuous development of root to complete root formation. Sensitivity to electric stimuli or stimulation. Electric stimulation, one sign of vitality. It's most sensitive to this, not indicated of necrotic. Dentine bridge following calcium hydroxide bulbotomy with the life of sure is calcium hydroxide, one trademark of calcium hydroxide. Thank you.